reducing with the functions over time. So that seems the idea to control, to offer at least the control to see, okay guy, now you're okay, but maybe next year you're not okay, or
yes,
you're decreasing, then that's a good approach. If he's not interested right now, he must be consulted. But now I'm the devil again. I'm the devil day for you. So now the case was here a question for adolescents. So now you have not the 20-year-old patient, but now it's a 16-year-old. So he has a normal maturity. Of course, he's not making sex with females, but he's doing at least masturbations. So we have a normal sexual function. What are you doing in this case?
What about the physical examination findings? For example, if the testicular volume is like Tanner stage 5, smaller than the same age population or different? Small means?
More than 10% difference between the two.
10%, okay, you get the case. I will offer you the case. 16-year-old boy, normal sexual puberty. He has a normal Tanner stage of 4, so the hairs are growing up normally. The testicles apparently are a little bit smaller, well, not acute, but there's some slight difference between left and right. And we're assuming the left side is smaller than the right. So now it's coming to the doctor, and you have to support her. What you're advising here, what should you tell her to the patient?
I would offer the patient's family to say that just sperm parameters will be deteriorated in half of guys over the years. So it means, but will not be changed in 50%. So it is up to the family. So if the affected, I would offer first varicocele repair in those patients because there is no irreversible.
So offering varicocele repair seems reasonable. So you're saying, okay, we're going to offer it. But if you're going to offer the varicocele repair to the patient, are you asking for a semen before? It's a boy, 16 years.
16 years.
16, post-puberty, of course.
Yes, post-puberty. He could have Tanner stage 5.
Yeah.
Yes, we can see the semen parameters.
You would ask, so you would request semen before surgery? Okay.
Right.
That's important.
They are saying 50%
now we have a problem. Okay.
Deteriorated.
But Professor, we have a problem here.
Right.
So because this boy for 6 years is living in Morocco, so I think he is on religions. Are you going to ask if he is doing sex? Are you going to ask if he's masturbating?
Yes, some people could argue if it is ethical to get
so you see
to ask semen analysis for a boy with 16 years old.
So we would agree that it's important, even less from the culture, to push it, to be honest, because obviously we know that he makes masturbation, and now we're going to ask him, can you provide a semen analysis? Even as it's embarrassing the first time, you have to be a soft touch to approach this one, but the arguments are there, because he will have the best chance to survive, and he can head over more, he can have a catch-up of the testicular size. So it's important to understand that minus 10-20% in the adolescents can be after surgery where you retouch the same volume of the testicle. It's important. So that's the reason the indication to make a surgery, I think it's a good approach, and you have to ask it. And what do you do if it's 14 years old?
If the testicular size difference is more than 10%, actually not 20, more than 10%, I would offer the guys and his family to have surgery.
Okay, so your question was now resolved. You know how to deal with your patient. So now I have the patient 21 years old, and you have the younger one. So you have resolved the question. Okay, great.
Before age of 14,
Good.
most of the adolescents with varicocele will get catching up.
That's
before
important.
age of after the treatment, before age of 14.
So with this conclusion, you have two options. There are two major opinions. The first one is that by the varicocele repair, you are blocking the sperm degradation, the central cells, and maybe the Leydig cells too, but you're blocking this decline with probability.
Right.
And the second information included in at least in adolescence, that he can regain his testicle volume, have more central cells, and more spermatogonal cells. So there are two information in this statement. So it's an important statement. So Dr. Selahittin says, okay, do that. But in the background, he knows the data that he is offering you two options. And that's important. You see, his answer was clever because he is arguing for two options. Bravo, bravo. Good question. I like it. Someone question more in the audience? Yes? Sergey from Russian. Come on.
I have a question.
So, Sergey is from near to Moscow in a city around 600,000 people. He is working as an andrologist there. So, I introduced yourself, Sergey. Come on.
I have a question to Professor Cayan about interoperated Doppler. How you use it? You scan all vessels in, or you use it for looking for artery, or
Okay, go ahead.
or only for control your work?
I don't use a Doppler probe, but just to show, I just used one time to show.
Oh, really?
Prepare the video.
Okay, so
It's
we're
not-
different.
I think just maybe yes. Sometimes you can drop a little vasoactive agent. to
What are you
see
using?
pulsation.
Gave him information.
Papaverine.
Okay.
Papaverine is
Me
very,
too.
very
Cheap,
Cheap,
easily,
very cheap.
working fast,
Yes.
with good information. Take
to
it with
see.
you.
Yes, very
Take it
easy.
with you, so you
very
use the
easy
papaverine.
to drop all over the vessels, on the vessels. It's easy. It's enough. I don't think Doppler probe is necessary.
Okay,
But
so
if you are a beginner to perform microscope, then you could use a Doppler probe to identify. Because even if you put the probe on the vessels, you cannot identify which one is artery. It's not easy because the thickness of the spermatic cord is less than 1 centimeter. It's not easy
okay.
but you can use your two fingers to create plane position, not like spermatic cord, cylindric position. Then you can easily find the
Okay.
artery. If you create it, just try to create plane position using
Okay.
your two fingers.
Okay. So I will show you now a secret. Okay? Because I'm doing it a little bit differently. So I will share it right now.
Okay.
So I saw the picture from the Doppler probe. Of course, Doppler is already usable not for the venous but for the artery. So it was mentioned at least 3 arteries searching, and I saw his intraoperative Doppler. And I use another one which is a tip from around 1 millimeter. I have another one model apparently from the US built. It's not so expensive. The machine is 2,000 euros, something like that. Then you can go to see the artery because it's small. You can identify plus minus papaverine in the case of, and you can. This is 22 megahertz. So this Doppler is really high frequency, and you can identify it a bit better. And the next trick is to be careful always what the anesthesia are doing upstairs. Because anesthesia, so at least I'm doing in general anesthesia, I don't know in local, but even in general anesthesia, because my patient.
Spine anesthesia.
Yeah, so spine is maybe a good idea, but we are using general one, and then the pressure can lower. So what happens if the pressure is 100 to 60? So the mean pressure will be around 80. Then you will not discover you have difficulty. So I'm going always to say to my anesthesia, come on, increase the pressure, and he gave a little bit of adrenaline. Then he has a pressure of 130, and it's easier for me. So you have 2 choices, I say to my anesthesia. Or we take him longer, or you're going to increase the pressure. If you increase the pressure, I'm faster to find the arteries. If you don't do that, because you have the pressure with 90, systolic 90 to 80, 19 to versus 50, so a middle is 60 is too low, because you have a lifting and you have a compression, and then you have to think about that. So that's the reason my trick is, go to the anesthesia, say, increase the pressure, make a little stress. If not, I have stress with you. Secondly, I use this probe, that's a good idea. And the first trick, that's a trick, because you're feeling the artery. He has platin fingers. I don't have it, so you know, I'm a stupid man.
No,
so
I'm
what I'm doing,
ices to see pulsation.
so what I'm doing,
Finger.
so that's a trick,
Just to create plane.
Yes,
Go ahead.
there's a trick. If you use the double forceps and lift below the veins and lift it up under a microscope. If it's a vein, you can block the vessel was coming here, and you have no pulsation. So you have to go some micros up and down, and to see. Now, if you're going down, the blood flow will run. If you're lifting up, can you block it or not? If you can block it at this moment, you see there's no pulsation, then you know it's a vein. That's a trick. But an artery, you will see also some pulsation on the artery side. And the vein, you can block it immediately. So you can distinguish even less. So it's not easily, because we are trying to block everything. We find everything. We're not using cautery, we are only the best we're doing. And then we need at least 3-4 steps. So the same as like you, maybe another machine. It's an old one, 10 years old, but it's working since 10 years with the battery. The only issue, the battery is always going charging. So we have to
One more thing to tell you, there is another problem, which is that artery is surrounded by at least a few internal spermatic vein channels. So even if you identify the artery which is pulsated, it's not easy to ligate the rest of the vessels under microscope. That's why you have to.
Indeed. It's the problem. Like I said, it's correct the argument. If you have here the artery that's coming down, one of the arteries that now is the arteria, what do you mean the arteria centralis? And the other one, so at least 3 are searching. Now he's arguing that, well, the veins are crossing.
Right, a few.
And there's another one,
channels
and you have to
veins.
be careful which is the right one. And in the background you have here, but I was not working anymore. And in the background you have this, he stated you have to preserve the lymphatic vessels. So you have another problem. Unfortunately, these are almost near here. Unfortunately, this is here. And it's difficult to differentiate, is this a vessel? One time you touch, you can forget it. Because one time you have one touch with the forceps here, this will cause you a higher risk for hydrocele, secondary. So even as a touching from this lymphatic veins is a problem.
Right.
So indeed, in this picture, the video clip is so perfectly done. It's amazingly good because it didn't touch it. But when you touch one time, forget it.
Right.
The artery, you can maybe touch. I'm not consulting you. Use anatomic, not surgical forceps, anatomical one, without the ribs inside. It's another trick. If not, it's working. And the vein, you can touch one time, so not second time. Because if you touch it one time, you can close it, and you cannot identify it hereafter anymore. So that was shown here extremely good in this video clip from you. I realized immediately. It was a great, you can make an applause. That was great. I realized immediately.
I put first more.
That was great.
That 3,000 cases.
Indeed.
Yes.
Okay.
Thank you.
Other questions?
To
Yeah, there are a few ones. Okay, we're starting here.
Dr. Ahmed from Iraq.
Okay.
I want to ask about cases of subclinical varicose in patients who present 3 years after marriage with normal spouse and idiopathic fertility. He has some element abnormalities in the analysis.
But he has clinical palpable varicose.
No.
No, it's not.
Well, we have a
The
problem
case-
here. That is a patient, a young patient, which has a secondary fertility problem because he hit the father once times.
No problem.
A primary.
3 years
Yeah, well, at least.
after marriage.
Yeah, well,
Are you talking about
The marriage
the
is not
case
a
I
key.
presented?
No.
no, in general.
Ah, okay.
In general. But
Oh,
okay,
sorry.
so then we
Say
don't.
again the case. I forgot.
Yeah.
Case 3 years after marriage, primary infertility, present with subclinical varicose and
On both sides.
semen analysis, idiopathic oligoasthenospermia.
I wouldn't fix the varicocele. I wouldn't give any kind of treatment like Fabrizio mentioned. Maybe he can make a comment on this. I would forward the patients to IUI or IVF according to his semen parameters.
I think I will do the same.
If
I
you
have
don't
no
notice
data,
per count,
I have no data that a subclinical will do that. But I have another question for you. So, you have a patient with a varicocele. So you measure or you palpate the varicocele, you make a clear diagnosis of the varicocele.
in the
No, in general.
secondary cases,
Generally,
no.
no, you have a patient with a varicocele. Okay, you have a grade 2 varicocele. So you have done a palpation, you know his testicle volumes, you know the sonography,
Okay.
okay, from the testicle, okay, varicocele is there. Do you do a sonography of the upper urinary tract, for the kidney, renal peritoneum?
No, I didn't. I don't do.
Okay.
I don't perform
Is that
general
good?
sonography in.
Is that clear why I'm asking this question? why I will asking this question if he's doing
If the
a
case is
sonography?
bilateral varicose, has bilateral varicose,
Oh, wait.
then you are
Too fast. You're too fast to read. So we have a left side varicocele. The request was to do a sonography, a clinical investigation of the left testicle. Okay, that we agree. Now the question for me was provocative. I'm asking him, should we investigate the abdomen? Should we investigate the kidney? What do you think is the reason why I'm asking?
Looking for a tumor kidney tumor that may be the etiology of the left varicose.
Correct. So, indeed, that was my question now. Should we investigate to understand why he got the varicocele? Is there a tumor in the kidney, for example, left side, which compromised by compression the venous backflow, and that caused the varicocele? Because then I can operate what I want, but it will have always a varicocele, and he has a tumor maybe there, or more hormone, what else? So the statement here was, no, it's not important.
because
In the left side.
young population we are seeing.
Okay.
It's not, and also very, very rare.
But that's correct.
Right varicose.
And the key was that was one study done in US, around 500 cases plus minus, and they stated, no, it's not so important because the probability to find an issue is low. So I admit that we are doing that. We are checking each time because we want to know it. But now I'm provocative, so I'm changing my question to the expert here in the panel. You have a bilateral varicocele, right and left side. What do you do in this case?
But in clinical practice, we see bilateral varicocele in 1/3 of the cases, so it's not feasible to
Okay.
see upper urinary tract.
Then you
or
not do it,
presence of
okay?
bilateral
Now,
varicose.
okay.
If I see only unilateral
That's okay.
right varicocele, then I want.
Okay, then was the first question. For the unilateral right side, which is around 5 to 7% of all the varicoceles on the right side,
Right.
so isolated right side, then
I should see.
you will do it. Indeed, I published one case, for example, you can look it, it's published, what happens if you overlook it, and the mess would I would undergo if I operate these cases. There has a portal vein shunt system, and I was happy that I didn't operate these cases in the last moment, saying, well, I have a bad feeling, let's do a CT scan, and that was right, so that was published. So be careful on the right side, maybe think about or look to the patient's age or the history, if it's bilateral, and I think on the left side we agree it's not always
Right.
necessary. Okay, great. There's a lot of questions. Yeah,
I have a comment for
Come on.
retroperitoneal evaluation patient varicose. Yeah, we have at least 3 criteria for imaging of retroperitoneal. Recently noticed by the patient, high-grade varicocele.
so,
Non-compressible.
sorry, you're fast, so you're an old man. So it's a high grade varicocele, grade 3 then,
Noticed by patient by himself.
not palpable.
Recently noticed and present for this problem. I think this is an indication.
So you mean it's a new onset?
Yeah.
Okay,
New onset.
so that's clear. So if you have a 50-year-old patient which suddenly had it, yeah, I think that's suspicious, yeah, okay.
Non-compressible varicose.
Why non-compressible? Why non-compressible? What means that?
If it is non-obstructive, it
But
will.
which varicocele is not compressible? Each one you can compress.
No,
Sorry.
if there is retroperitoneal tumor, it is
You can
non-compressible.
compress it each way.
It will not disappear when lying down.
You can compress it.
This is suspicious.
You can every compress every week.
No.
Sorry, but you can compress it easily. I never saw that you cannot compress it, okay? But it's a good idea, so
And
that's a good
it's
comment.
the right side, it should be.
Yeah,
Right.
but it's a good idea if it's a new onset of a varicocele in an elderly patient. I think that's correct, and think about retroperitoneal process like tumors, kidney tumors, morbus hormone, fibrosis of the retroperitoneum, something like that. That can be sarcoma, yeah, all that can be correct. There was one question on the. Who was there? One question? Yeah, you.
I have
sorry.
a question, but it's not related to the topic, if you may. It's about ejaculation retrograde ejaculation.
Hot topic. I think we will exclude that. I think retrograde ejaculation.
Okay.
I think it's too off topic. It's,
Yeah.
it's
we
coming.
will have many sexual disorders.
Indeed. So it's
This is the
covered for next
session.
time.
Yeah.
Okay? that should be covered. Other questions related? Yeah,
What
so
about bilateral varicocele grade 2 with normal semen
On
parameters?
physical examination, grade 2.
Yes. With normal semen analysis, semen parameters.
Infertile man or
It's
just
normal.
as
It's
a
normal.
No,
No,
it's,
it's
it's
normal.
not. He's not married.
not
but
married.
normal semen parameters.
Normal
sources
semen
fertile. Okay.
parameters with grade 2 varicocele, no pain, asymptomatic, and he has leukocytospermia, eospermia.
What?
Yes, is it caused by
Eosperma.
yes? Is it caused by varicocele?
Leukocytospermia.
White cell
Yeah.
in the ejaculate.
Yes,
but
white-
if
white
that's
cluster.
different topic to treat. If the
But is it caused by varicocele?
No.
no,
Come on.
No.
Please statement. No.
This stage is
clearly no.
no.
50 years old man, clinical varicocele, stage 2, impairment of spermogenesis,
Okay.
not a typical astenospermia, moderate oligospermia, okay?
Okay. OAT grade 1. Okay.
But wants to
Female-
conceive or not?
New
Just
partner,
New partner.
female
Happy
partner,
man. Okay.
30 years old.
Yeah.
Not 40, okay? 40 means it is
Yeah.
clear that you go directly. 30 years old. Do you think to fix this varicocele or not?
if they want to conceive naturally, yes, I would.
A
My
woman
answer would
30
be
years
yes.
old
30
wants
years
to
old.
conceive
I would
naturally.
fix the varicocele first, then after the 1 year of sperm parameters, then we can
The thing behind the question is if somebody has a varicocele and is already 50 or 55 years old and the sperm parameters
Increase is there, so there's no reason, and no, it's not anti-Sellah syndrome. So, what's idiopathic? So I'm figuring out. I will ask you, can you help me? What's idiopathic?
we have seen many cases.
In many cases, if not secondary, genetic causes.
Which genes?
I
then?
think that
So if you're saying to me it's
the better.
okay, but if you're saying to me it's genetic, then I'm asking, okay, when I know it's genetic, so which gene should I order? So the colleagues is asking me, what should you do with the patient? He is suspecting he has the low LH, low testosterone, and you have patient 20 year old wanted to know is that idiopathic or not, or is it a cause? So you're saying, yeah, it's idiopathic. And I ask you why it's idiopathic. So then you have to.
You can try any cause, any cause. Simply, you cannot try the cause.
Well, I'm not convinced.
Yeah.
It's metaphysics.
So I think.
These parts are not correctable pathology, so I don't.
Well, I think we have a good tool in the hand. If you go to the genetic and ask him, hey guy, help me a little bit, and then he has to see is it Kalman syndrome, then he's checking KAL1, KAL2. Then I can ask him, can you check the Kispeptide, for example, can you FRG1? So there are around 10, 15 genes which you have to exclude. Only then I can say is it really idiopathic because I excluded gene causes. So it seems you have to force your genetic guys in the lab to say which one you did check it. Because he's saying on a Kalman syndrome by one gene, forget it. Kalman can be Kalman gene positive or negative, he can have still a Kalman syndrome. So there are many genes, and that was I wanted to address it. There can be many genes which can cause the idiopathic, can determine that you have a congenital idiopathic hypogonadotrophism by genetic causes, and that's not idiopathic anymore because there's a gene behind that. So you have really to see how many genes are there, and only then, when you exclude this one, you can say it's idiopathic. So that's a really crucial question. So really hard. So the key message for you would be, and for that reason I ask now Dr. Castiglione for it, on base of this talk, you have to force your genetics that he is doing the right information. Don't trust him when he say KAL1 gene is fine, and ask him what's the KAL2 gene? Okay, what was Kispeptide gene? Did they check it? No, they didn't check it, so they cannot say it. So you have to force it a little bit, and they make all this fast tracks examination, and now you have to go and say, come on guys, look in detail. And that was a key question, so go look in detail always. Other questions?
Okay.
Here's the expert. Ask him.
I I want to ask about 17-hydroxyprogesterone in the evaluation of.
That's amazing.
How to use it? It is intermediate between cholesterol and testosterone.
About the likely to
Elevated
prior
in case of
yeah.
poor spermatogenesis.
Intermediate between the intratesticular testosterone. So it's possible to check this value to repeat the same.
Is it elevated?
You're saying always. Okay, the progesterone is a clever idea. I learned it myself from Professor Corti because I phoned him for the strange case, what should I do? I'm exhausted. And he gave me the idea, check this one. And I learned it. Until now, I didn't observe it, but I think it's a good idea to check this hydroprogesterone too. So it's not my daily routine, but I think that's a clever idea. I learned to support this one. That's a good idea. I think we have to change our mind. I do like this idea, clever idea. So,
What is your...
so you're coming from there? You're coming from where? From Agadir. So now,
I'm biologist.
biologist, great. Okay.
What is your response for the man who do not accept the church intervention and repeat spermogram every 3 months, etc.?
Why you should not accept? Sorry.
Because for his sexuality.
But he makes sex every week. Oh, sorry. I will ask you the next question. So, what you tell me?
I didn't get the question.
So the question is, we have a man here who is who didn't like to have every repeated control every 3 months of a spermogram. I don't know why, but at least he didn't like it. So what you're saying to this man? That was the question.
Because the sperm is altered.
Yeah, of course. The spermogram is showing infertility, and you ask him correctly, okay, prove me 1, 2, 3 times if it's a stable situation, it's worsening, or it's been going better. So you ask him, show me 2 spermograms. We learned today after 10 weeks, Professor Colby.
Yes,
me too. So we are doing the spermogram always at a certain time, but we are asking several times. That's correct. Never do on any diagnosis 1 spermogram. Forget it. If yesterday had a bad night, forget the spermogram the next day. If you have a night shift work, forget the spermogram. So we are stated 2 spermogram minimum.
Yes,
Minimum. In this case, here say, no, I gave you 1 spermogram, we have a bad spermogram, and he's not accepting the controls. So what are you doing with this case? Okay, I would say the same. So I would say to this gentleman, say, okay, sir, if you want to have a baby, you have more problems in your life if you don't make sex.
Problem. They don't have
I will explain it this way. If you want to have a baby, you have to work together. So that's a clear answer for me. If you want to have a baby, we have to work together. Is sex harmful for you? If you have a phimosis that you cannot masturbate, then I will operate your phimosis and you can make masturbation and get sex.
Psychological consultations.
Well, if you need it right now for the spirit of psychological consultation, I think you should not father mine anymore. Sorry, but take it on seriously. Not fathering, better. Okay, joke by the side. Other questions? Professor, come on.
You receive a patient 17 years old with grade 3 varicocele, left side, with painful. And also he asked because he has many interest in a great interest in sports. He asked you the question if there is any impact of the varicocele on his performance and especially on his testosterone.
But young, it's 7 years old.
Yes.
Yes, there are many studies reporting that the testosterone level will increase after the treatment of varicocele.
Even less than
Also
70 years?
Yes,
Oh, I
yes,
didn't know that.
right.
Okay,
yes.
good.
There is also meta-analysis.
Bravo.
Not
See,
only
that's a real expert. He will show me what's the
significant
super.
improvement, significant increase in total testosterone level after the treatment of varicocele, and also after the treatment.
But in any case, it was the
Pain will be resolved in
Indeed.
9% of patients.
In how many percent?
9%. 90%.
90%. Indeed, I think just the fact that you have an adolescent of 90 years, 70 years old man, which has painful varicocele, the pain for itself is indication to do our varicocele repair. In this case, I will ask you, I'm provocative again, should we do, he has a painful situation, that's a primary, should we do a spermogram in this case?
Pain is secondary indication, not primary.
No, but
if the testis is not affected,
his complaint is his complaint is here the painful situation. Is nothing else. Pain.
okay, I will first give the adolescent, the guy to just any painkiller
But if he has persistent pain, so you get
persistent pain.
not
I will fix the varicose
Yeah, you will
because
fix
we know from the studies 9 of 10 will get
a benefit.
some benefit,
Yeah.
partially or completely. Doesn't
And
matter.
are you requesting regardless is pain complaint of pain a spermogram?
Of course,
Of course,
sperm
yeah.
parameters will support our offering. If it's abnormal,
Okay.
then it will be easy to offer the patients to get.
Well, I would say no. So
Ah.
I would be delighted to have it. That's my answer. I would be delighted to have the spermogram, but his primary complaint is a painful situation. Therefore, I'm not interested in spermogram, honestly. So I'm not requiring. It's my personal interest.
Yes, true.
It's my personal interest.
But we
It's
should
an academic
offer-
interest, and I will be delighted. But he's saying, no, I have no interest because I don't like masturbation. I will operate nevertheless. So
Okay.
here is a statement of my
But
side.
we should offer the patients.
Bravo, we should offer, but it's not
to
mandatory.
have semen parameters.
The guideline will say
It's
a
not that.
painful situation is enough. Please.
To my way of thinking, I will try to persuade him to have a sample, because maybe later on, if something happened and proves that it has some impairment of the sperms, maybe they say that your operation has to blame.
Well, that is a legal point not to follow, because if he comes 5 years later after a varicose repair, why should some law follow the direction that it's linked to this one? I would not say that's clear. If they are 5 years later, the testicle shrunk and not here, then I think, yeah, I've done something bad, I think I have a problem, but then have it over the other side, which will be completely compensated too. So I think that's, from a legal point, I would say go ahead.
It should be offered to patients, but if they don't want,
Okay.
it doesn't matter.
Is the WHO definition applicable to 13 years old?
Two?
For
13-year-old?
13?
Yeah.
13?
13.
No.
No, that was 17. This was
17.
post-puberty, so that was important.
Yes.
But I'm always
After
asking, it's
standard
post-puberty.
stage
Yeah.
5.
Yeah, that's post-puberty, then it's working, yeah. Okay.
My question, if the pain does
Pain.
not disappear after varicosectomy, the 10%, and enter the stage of chronic orcalgia and depression.
Yes, for
Do
other
you
reasons.
have, there is a rule for skeletonization of the spermatic cord? You did some.
After the surgical treatment, again.
So the question
if
here
the
was,
pain
okay, I will summarize.
Doesn't resolve in patients with recurrent varicocele or in patients
No,
with
I will summarize. The
varicocele?
question here was, patient underwent a varicocele repair, and he get by pain, that was his complaint, and even less the surgery, his pain persistent. He has always pain in the testicle, in the left groin, he feels not comfortable. The question now is here, what should we do? Offered was here a really intensive operations, or what should we do?
But
As
it
the last
depends
one.
on the presence of recurrence.
There's no recurrence, pain.
Does-
No, just the pain.
Only pain.
Chronic or
After the surgery, right?
After the-
You are asking. And you confirm there is no varicocele on ultrasound.
Organic cause.
No varicocele.
Okay.
So the question is good, because
I
it's,
see,
it's
okay.
addressing the question. We have data. One times you're lifting up the plexus pumpiniformis, and you're doing it correctly. The facility, if you look someone, use a backcom clamp. I saw he first time he touched in this video clip on this side here, used a backcom clamp, lifted up, and then was his finger lifting up. So I was saying, with this one, he's not touching the nerve. They happens, but the nervus genitofemoralis is crossing over the plexus pampiniformis. It's not going only in one direction.
Right.
It has a probability from 40% to 40% to go recurrent upsides, to have a recurrent right, left, left, right. You have no idea what's coming up. So even less, in this video clip, it was a subinguinal, didn't open the annulus inguinalis externus, it was inguinal, he has to be completely nerve. And now happens, if the surgeon, no, sure, not the expert for 3,000 surgeries, but is using a little bit of current, then he will propagate the current to the nerve, and the nerve has a problem because the nerve makes the pain hereafter. Right. So the varicose was operated, but the nerve or is cut it,
right,
or it get a disturbance by the current or by the tension. It's a little bit tension is enough. So that's a problem. First indication what you can do always, if you're climbing by the surgery, use always a continuous irrigation solution. So I'm using it, so my assistant is always to put a little bit of water, because if I'm using current, then here should be surgeon water it, because to take away the camera effect.
Right.
Camera effect is critical. So if you're touching that. And now, let's say we have done one error, we don't know exactly which one, the nerve may be preserved because the sensibility is there, and we can check the sensibility, ask him if he has a sensibility on the inner side of the ipsilateral operated side of the overshank, of the legs, and the scrotal ipsilateral of the inner side. That's the nerve what's causing. And you have made the discrimination between right and left and know, okay, maybe the nerve has a neuropathia, okay? There can be a denervation, and the denervation can make pain. So now we have the patient with the pain. Now I'll ask you, what are you doing with the pain patients? Shit, he has pain.
I don't perform nerve denervation for pain.
Okay.
I don't have any idea.
So how to treat? Well, what we can do, that's a trick. So at least I try this trick, and sometimes it's working, sometimes. So I use, the key question, the nerve is a propagation process. One time is initiated the nerves, even less the nerves intact. So normal sensibility, nerve is there, but the nerve makes a problem in the brain because the pain is centralized. It's coming up. So then I want to know, can I block it? You have to block it. With oral medication, for oral medication, they are refractory. So you gave it diclofenac for 1 week, 2 weeks, 3 weeks, and he still has the pain. So you know, oral medication is not working. Then I'm trying right off now to use a local infiltration in the external ring and put it there. A combination of lidocaine, a short-acting blocking of the nerves, we combine with a middle-long or a or you can apply a little bit of cortisol, and then you see if the pain is vanishing immediately. Then I know I'm correct. And if you do that repeatedly, sometimes you can solve the issue correctly. If that's not working and still the pain is persisting, then maybe it's the case that you have to redo the operation inguinally and divide, surgeon knife, divide it simply. No other chances you have. Now, if you find the nerves under a microscope, you see the nervus genitofemoralis, go there and divide it and take it out a long distance without no granuloma. It's important because the nerve, when you're dividing it, can be on the microscope that he makes here some kind of granuloma. So you have to divide it with a large distance from long parts. Go ahead. Explain him that he will have no sensibility on this side. It keeps 1 year that send the nerves coming from the other side moving on the other side. He will have a hypaesthesia or dysesthesia, but basically it's the only treatment we have.
The patient will again come to you to see you.
I'm saying everything to you. Come on, to me. I'm saying everything to you. It's up to you. But this one maybe one option for you. Okay. Other questions? Use the expert.
Correct.
One last question for you. Increasingly, I've been getting patients who are not infertile, who just had a thought that they want to have a baby, but the man has come and he's produced a semen analysis and he says he wants you to tell him he's okay, and he's got some oat and a chemical varicose. So would you intervene when he's not yet infertile because he hasn't met the criteria, or would you wait?
In the presence of normal
AOT. Oligospermia, so grade 1, grade 3,
But
doesn't
they
matter.
don't want to conceive now.
No,
Just starting.
well, to think about, so it's not clear, maybe in 1 year, 1 year, 2 years, 3 years, I don't know if your wife is like
I will fix the varicocele in that case.
I will fix it too. Because it can
That's
determine the data.
Candidate.
That's a good candidate.
But how
And
many
improve.
patients with oligosteroid are infertile? How many?
Among the population
Yeah,
with
so I
varicocele.
yeah. Because I'm sure that patients with oligosteroid who are fertile. So what's the percentage of patients who are infertile?
Okay. So the question is difficult.
But
the question
one
is,
of the indication is
No.
having abnormal sperm parameters in the presence of
But you haven't
varicocele.
defined infertility.
indeed, the problem is,
In general population.
yeah, in general, probably. The question is, what is the percentage of OAT to incline to determine the fertility? So we can answer this way. The fertility should be done in a young couple of years within 1 year. If in 1 year it's not working in a young population, then we have a problem. So if the normal cell count will be, let's say, 4%, I can guarantee that within 1 year we will not conceive it. And the definition of OAT is not enough for me. I would require to have more information is OAT grade 1, grade 2, grade 3, and is solitary, measured by 1 times or measured by more times. So then I have a better clear picture. That would be my approach. I don't know how
Yes,
do
the same.
we do that?
Yes, same.
Okay, so repeat the examination. Is that your consultation? Do a second seminar analysis.
Not now, maybe just if we see two semen analysis, I think it's enough to.
2, okay.
Not necessary.
So not
to
1
see
and the
third
2.
one. Yes.
And then by the 2 examination you will decide what is the way to do it, or we are doing immediately surgery, or we are combining surgery with
if you are asking
antioxidant.
how many or what percentage of men with varicocele in the presence of oligosteroid will be infertile, I would say just 1/3 or half of the cases, right? Half
So
almost.
why would you choose this man who hasn't yet?
Really
Done
good,
the
because
12
if we
months?
deter, it was over time, it's probably been worsened. So, and I think maybe you can combine it with a short term of pre-operative antioxidant therapy, and after the surgery again antioxidant therapy. I think
Yes,
that's an approach that
yes.
you can combine it to. So I would say do double. So I'm doing double. I gave him a little bit of antioxidant therapy, explaining that we have no clue which one. It's combination therapy normally. We cannot trust the ones on zinc or hormone formulation, so as a combined therapy. Maybe we use the time of the surgery, then we have a second experiment on the first one, make a surgery, go ahead and then see what's going on. At the same time, I advise a little bit my patient to change his lifestyle too. At least I'm doing that, I'm trying to make a little bit more healthy, more sport. It's sometimes working. And the data show that the decrease of body weight after consultation is minor. You can expect 30 to 50% will follow it and will not will have a better BMI in the controls. But you can explain, go outside, make a little more sport. That's really good. Up here, that's good. So that was shown. Sport activity is increasing.
I would also ask you just to why that patient you were presenting came to see you. Should be a reason because some people we don't see some people who don't who are not complaining of anything.
They want to make sure they're not the problem.
Yeah. It's affirmative.
Yes.
So indeed that's good, but I think you cannot exclude that they are the
Even
problem.
it's an
So, but you know,
indication to offer
for the man, it's
surgery.
easy to say, I'm perfectly, my wife's a problem. So now you have to say, no, sir, you might be the problem, not your wife. And your therapy is easy than for your wife. I think we agree. Is it from a gynecology point of view correct to treat first line a man, partly is a young man and a young woman? I think the treatment for the female is more complicated as long as you have no PCO syndrome or any specific hormone disbalance. I think we should go primary man?
But all female partners should also be seen.
That's why.
Gynecologists.
That's why the guidance
Yes,
here.
yes.
That's why the guidance.
I just add a point here to her question. I think if you are being presented with a case of OAT and you are seeing this patient with the concern that they want to be clear that they don't have any fertility issue, then I think you are morally obligated to advise the patient that there is a possibility that you may become infertile progressively if you wait for another 4 or 5 years until you are ready to try to have a baby. At that time you may be completely incapable, but we have a treatment, we can treat you, we can operate upon you, and this will improve the quality of semen. Now in terms of your original question as to what is the incidence of OAT in patient presented with clinical varicocele, I think it is difficult to tell, but I will say in general we say that about 35 to 40% of patients who present for infertility have clinical varicocele palpable, and I will say maybe half of those patients could have any type of seminal abnormalities. Whether they will have OAT in combination is difficult to say that they will all have. OAT is a special kind of seminal abnormalities when all three issues are there for count, motility and morphology. But in combination, either abnormality of semen count or could be motility, these can be there. It need not be that all three are to be there. They can still be a concern in terms of poor semen quality. OAT need not be the only litmus test to operate. Is that correct?
Right.
You will operate even if it is oligozoospermia or severe oligozoospermia or steno or teratozoospermia. That should still be an indication. Or you can have another examination of semen quality after maybe 2-3 months and then see how the semen quality appears.
Maybe we can go a step further. So the normal WHO classification, what you're referring for the semen analysis, is not the crucial only issue. We can address other factors as like the BFI, the sperm fertilization index, or other ones which are maybe more indicative and are supporting your concept. And secondly, you're in the lucky situation that you have been here because today you heard from Professor Selahittin the first published meta-analysis which is proving by the meta-analysis this high scientific level that the varicocele repair has a huge benefit, because that was not clear in the last decade. There was one study, yes, that was rechanged, which we don't know, and so on. So basically, quite often had been certain colleagues is always questioning, should we do it? We have no data that the baby take home is going better, because we had in the past the famous Nischlein study in Germany, which showed that even as you're doing nothing, the pregnancies, the baby take home rate is the same. And that was a huge impact because that determines you have to do nothing, they will have a baby even less. And that's wrong, because this GAF, this for the Global Andrology Forum, initiated and done highly complicated study. You know, you have to look every paper in the world, every manuscript, you have to scrutinize it, you have to see every language, you have to do it, you have to use the English one, the Italian one, the German one, the
even
Swedish
Russian.
one, the Russian one. So there have been so many publications. I remember that I was always asked, can you translate it from German to English, someone? And say, well, it's a nice study from the 16th, so old studies, every study. So I got an anatomy study from the 60s, 70s from Switzerland, and say, wow, amazing. I learned a lot what they have just done in the past. So everything was done only to have this database, and by this validated database, by a ranking about the quality, by scrutinizing, then there was the data what the professor here showed the benefit. So you're in a lucky situation that's not a normal common knowledge about urologists, neither from andrologists. So you're in a happy situation that you got here now the newest information, the newest recommendation from the Global Andrology Forum, and that's great. So my compliment for the presentation of this data, that's great.
Yes.
Something else?
Yes.
Then we take Professor
Rafi.
Martin. I know your name, oh you guys. Come on, Martin.
He wanted to become a urologist.
I might shift my career. Yeah.
You have to do something better. Okay, you see, that's we are fascinating, yeah. But not career, only you go not to medicine, no, you andrology, of course. Only andrology, okay, I accept it. Come on.
How many times do you guys test semen after vasectomy?
After vasectomy. Okay, after vasectomy, that means after cutting with idea, there are clear data. You have to do, no, it's not clear, sorry. That's a mess right now. The American society are saying you need one spermogram which is showing 100,000 non-motile sperms. In Europe we are saying, no, we want to see no sperms because we are confident with 100,000 not happy, because we know that there's a probability between 0.5 to 1% to have a spontaneous re-anastomosis of the basal. And then became pregnant and you have a massive problem. You have to consult by written that there's a risk existing. So we are asking 2 spermograms. The next question is, okay.
So in what time period?
Indeed, the next question is, when should that be done? So that's highly difficult. So the answer here is, well, we need at least 20, 22 ejaculations. So now the question is, how many ejaculations we have? This gentleman didn't like it every 3 months. You're not you, you're a patient, of course. So if he's doing every 3 months 1 ejaculation, he has to wait many months. But in normal practice, I would say to my patients, and that's a routine, 12 weeks after the first or 3 months, and hereafter after 4 months. There was the idea to shorten it, and sometimes I'm doing it. And I presented last year the data from the analysis from Austria, 750 cases, something like that, how many patients, even last they wrote in written informed consent that they are willing to do the spermogram after the vasectomy, did not come. So we will have been surprised, but our data have been similar to the Cleveland data. I checked it, so but you have to be aware, let's do it. So I would say we like two negative. But again, the guidelines would say no, 100,000.
Yes.
The American guidelines.
Right.
I don't know the Turkish guidelines.
No, Turkish guidelines.
No, you have it?
No.
No? Okay.
They follow the AUA.
Yeah. AOA, America is saying 100,000. 100,000 non-motile. But in the centrifugate or not centrifugate? They're asking in the non-centrifugate, no, in the centrifugate, they say, well, if you want that, just centrifugate, everything's dead, so much else. I don't know.
And after a vasectomy reversal,
Yeah.
it just doesn't need to come back to the
me?
parameters.
Yeah, sure. Okay, if I'm investing in this patient 3 hours to make a perfect anastomosis, if I'm using a needle which is finer than your hair on the head, and 9.0, 10.0 needles, so that's really fine needle, what you need, then I'm interested to see, and I'm asking about 6 to 8 weeks after you make the first control. So then my practice 6 to 8 weeks. It depends a little bit. If it's easily fixable, 6 weeks, 8 weeks, but I like that he makes sex because the fluid may be good, so then I'm checking. But I'm asking, surely, show me what's coming on, because I'm happy with the patient that is working.
One test is enough.
No, that's wrong. No, that's not wrong. Because after reversal can be at the beginning it's coming, and then by immunological reaction or by other inflammatory reaction is going down, and you have to intervene immediately. If not, he's not coming, you can lose the patient. So I have patients which I showed in the beginning had a good spermogram after the first control, after 3 months, and after 1 year, he was weak. Oh my God, now we can go to the ICSI. So now you can use this when you have it, but basically I have not operated anymore, but it's not very hard. So it can be after 1 year can go down. If after 1 year it's still valid, I think the probability is low that it happens nothing. I'm not going to control anymore.
Germar, about vasectomy.
Yeah.
Which is the latest semen analysis you ask from the patient to be The latest.
Yeah, the latest is for me clear. So I'm advising the patient that I need, outside of the guidelines, 2 spermograms, 3 months, 4 months. If both, if both are negative in terms azoospermic, then I say you're free, but you know that there exists within 1 year the spontaneous recanalization, and that's between 0.5 and 1%.
Yes.
And that's written in our inform before
Yes.
you operate.
And then
So we are not going to routinely check it again. He's informed. If he would say after 1 year, you know, I have a sex life with my girl, and we're doing so many sex every day, the probability is increasing, and she's so young and so fertile, then I would say, well, it's worth to check it again. No problem. I would say, yeah, do that. I will consult him, yeah, you should do that. Because the risk is there. And I remember one case in Germany from Munich, the colleague there called me, and this was one of the best surgeons, but I know, honestly, he's an amazing good guy. So I operated with him quite often. And he had one patient which get confirmed, perfectly done vasectomy,
1 year later.
and had no sperms. And 1 year then he get a phone call saying, oh, and actually, you know, my wife is pregnant. And he became nervous because he's working private office, and was thinking, oh, I have to call my brother, who's the famous lawyer there, because now I have a law issue. And then he asked me, Germar, have you data? What's going on? I said, no, that's the fact. It's the inside. We have this risk. And it was genetically proven correctly. That's the next issue. Genetically proven that it must be the son or the daughter from his father. Because only to be pregnant is another story. Sorry, but we have to be careful. Genetically proven. He provided that, and it was clear he was the father, and provided spermogram. Indeed, there have been new sperms there, and that was a problem. So we have informed consent for everything, and our informed consent has been adapted last year, and they added this line too, because that's not normal, that was something old-fashioned inside, so you have to consult by this case, and that was the reason done. If not, you have to pay some millions. Wrongful birth that's a law issues, is a wrongful birth, the case in Europe, is not included with death toll, and then you have to get paid for the whole life. So until he is 26 years old, you have to pay the university for this one, you have to pay everything. So be careful.
There's another explanation for that. My urologist used to call that it's a good neighbor policy. Maybe the neighbor helped him.
Indeed, but that's genetic analysis is already together. Okay. I think we have response all the questions in the panel discussion right now. Is there something open? I don't see so. Then I think, Professor Zimmer, we can enjoy one coffee again.
Yes,
Your
it's
hospitality is so great.
So
thanks a lot.
Because
Now we are concluding all of the infertility section. Okay?
Yeah.
Okay. Just to conclude, I want to ask, does the Islamic religion allow masturbation for producing semen?
Yes, to do, for example, an analyze. Yes, the Islamic approval. So if there is a medical interest, it's okay.
And sorry, then if I'm going to ask you, while your sperms are not looking good, I need and you high frequency masturbate every day.
Some people don't like to give sperm with masturbation, so they ask their wife to be with them in the.
And he's not married.
But I think everyone who's gonna have a spermogram is married.
No.
It's rare cases in case of.
You are opening a door. I want to explain. Okay. I am very interested in this. Okay. Because to know if the Islamic religion, not personal interpretation, the Islamic religion tenets, okay, consider the masturbation as a fault or not, independently of the problem of fertility. That is, I was a guy, okay, okay, and not married, and I was well, I was sufficiently cultured, and I decided to see if I was fertile, okay, and might, if I was Islamic, might I use semen for masturbation just for knowing?
Okay, doing
Not personal interpretation.
yes, doing masturbation just without any medical reason is forbidden.
Oh.
Is,
So the terms, I think,
it's
in
not
Islam,
allowed. It's a sin. But if there is a medical reason,
yeah.
it's not.
I think
So the
answer-
doctor who choose,
Please correct, but I think my knowledge from Islam means to put the sperms to the earth is not allowed, but to use the sperms by clinic indication is allowed. That's a key.
Yes, but Islam it
We have
depends.
allowed for
By the religion.
Everything which is necessary for
It's
medical
allowed,
for medical reasons,
Yeah.
it is allowed.
it's allowed.
Okay.
but the
Not-
put your
not,
sperms to
uh,
masturbation.
for
is
any
not
other-
necessity.
Not for pleasure.
And you completely
Yeah.
accept that.
Indeed, I say sperms on the earth for pleasure.
Okay, okay. So don't accept in this moment, just to conclude this session.
This is
with
the sexology
with the
session.
curiosity, okay? Because well, I had the misfortune, okay, to become a chief of an andrology department called by a religious people in their hospital. This happened in '88, okay? And they clearly know absolutely what means andrology, okay? After 3 years and a half of normal service, okay, I suddenly was fired with because I was accused of violations of the Catholic ethics, okay? Because my patients to perform semen analysis had to masturbate, okay? Yes, okay, this is
That's
history.
correct.
This is history.
I
This is
remember.
the problem.
That's even as for Catholicism too, not
Yes,
only for
okay,
Islam.
okay, because the only method accepted by fundamentalism, Catholic fundamentalism, okay, is that you cannot use semen only for analysis, but you cannot masturbate in any case. And if you want, well, when I asked, yes, okay, but how can we check the fertility of a patient? Okay. Well, and so I learned from a previous booklet that written 20 years before, that the only method was to use a condom, okay, with a little hole, okay, and the man had to have sexual intercourse, okay,
Is the aim to be pregnant?
exactly, because you cannot avoid the possibility of your partner remains pregnant, okay, so you cannot masturbate yourself, you must have sexual intercourse, but with a condom which must have a little or not so large that you lose the semen, but not so tight to avoid the possibility that one can yes.
So it should be
Why
100%
do you laugh?
contraceptive, but it
Why
should
do
be.
you laugh?
Yeah.
Well, I was fired with all my equip from the hospital.
I remember.
3 years and a half later, okay, and I could not forget, okay, this experience, okay. So maybe I will write something about
Yeah.
it.
That's a good. So makes an applause for the Zip.
You are now reinstated again.
And now thanks for the coffee break. Professor Imad, he invited us now to have the last break, and you are saying when you come back, which time you should come back?
15 minutes.
After 50 minutes, we pray.